financial interest to disclose at this point of time in the research, but we do acknowledge receiving the research grants from various international and national institutions. The basic natural history of the disease. What's the natural history of the disease? When you have a CNVM, there is always a one-line loss if it gets untreated at 3 months' time, and there is always a 2.7 line loss after.
Rohan, yeah, just do it. It's not coming.
Okay. Okay, fine. The basic natural history of the disease is that there is always a one-line loss at the end of 3 months and 2.7 line loss after a year of treatment, and there are 4 line losses after 2 years of treatment. So there is a significant loss that you are having or you are anticipating if you don't treat a CNVM patient. The worst thing to follow is that there is always an involvement of the fellow eye if you don't treat. That is 12.2% of the patients at the end of 1 year, and approximately 1/4 of the patient at the end of 4 years. That is all more reasons to treat. There is always a lava which is burning underneath and it is waiting for the eruption. So that's the disaster when it strikes, when it involves the other eye also. So what are the treatment regimens that you have at this point of time in the science? There are monthly and intermittent regimens. The monthly regimens are always like a continuous source of water cannon what you are throwing on the fire, so that the lava which is burning underneath, that has a water cannon over that. So I'll just go through the cases only so that you can always have a look at that. These are the day 0, 6 months and a year of follow-up, and all the sequence will follow the same. The red-free photo of the lesion, which shows an extensive resolution of the lesion when you compare from the baseline to the 1 year follow-up. These are the early phase at 1 year, 6 months and a year follow-up at 30 seconds, at 2 minutes, at 5 minutes and at 10 minutes. You can see on the top left the active lesion, which is quite significantly leaking, has resolved at the end of 1 year and sustaining of the scar tissues. The OCTs would follow the same course: day 0, 3 months, 6 months and a year of follow-up. The fluid which was present stabilizes at around 6 months time, and it had become scar at 1 year follow-up. The picture chart from the OCT, you can easily see that the lesion, which is quite big, has come to a smaller lesion size at the end of a year. The central macular thickness from approximately 400, that has stabilized, that remains stable at the end of 3 months also. So every time injecting 3 monthly injection does not solve your issue. You have to keep on injecting some of the patients. The CMT becomes stable at 6 months and then remains stable at the end of a year. So to conclude, at a monthly injection, that not only that maintained the base corrected visual acuity, but that also improved the lateral lines from approximately 2 lines respectively, but still has an ever increasing patient load, stress on the patient and the family members, and the associated economic costs. They are limiting factors for the monthly injections, and most of the times patients are also not willing to continue monthly injections. So then the idea came of an intermittent regimen, right? So Pronto and Sustain had the same idea. They had a loading dose of 3 injection, and then they explained for a monthly follow-up. If at all the lesion activates, they treat. So that's treat and observe and PRN basis. So we also followed the same regimen in some of the patients, right? This is the same sequence that we are following. On the top left is the day 0 and bottom is the 1 year follow-up. You can see an early phase of FA at 30 seconds, 2 minutes, 5 minutes and at the end of 10 minutes. You can easily see that the lesion got stabilized at the 6 months FA only, and it remained stable at 1 year also. You can see the OCT that this patient sometimes does not need monthly injections and they become stabilized at the end of 3 months. So there is no significant difference at the end of 6 months and 1 year of the OCT. If we see the picture chart of the lesion became quite similar at 1 year, and that was quite similar at 3 months also. So sometimes if you don't overtreat, that's fine, fair enough. The OCT central macular thickness achieved 180 millimeter, 180 micron, and that remained stable throughout the study period. So when we look at the results, they had a similar improvement from 0.85 to 0.58 with a significant p-value. So to conclude, the treat and observe regimens of a Pronto also that improved the visual acuity, which was comparable to Anchor and Marina, and they showed a slightly lesser gain in visual outcomes. So treat and extend, the other regimen what we studied, that's a loading dose of 3 injection, and then we increase the follow-up also from monthly to 6 weeks. So that is 1.5 months. And then when the lesion remains stable, we always increase the follow-up of 2 weeks every time when the patient came for the follow-up. So the number of visits, I'll conclude in a minute's time. So number of follow-ups also we were able to achieve with a significant decrease in the follow-up. This is the lesion size, FA at 2 minutes, 5 minutes and 10 minutes. The lesion, though it was quite big and significant, that also became stabilized at 3 months, and that remained stable throughout the study period of a year. So a bigger size lesion remained and became almost quiet lesion at 3 months interval, and that remained at 1 year also. So every time the lesion size does not determine the number of injections. Let's be pretty clear about that thing, right? So mean central macular thickness from 300 that stabilized to 210 and remained stable throughout the study period, even though the lesion was quite big, and we expected that we'll need 4, 5, 6, 7 injections to resolve that and maintain that at a stabilized level. The main best corrected visual acuity in treat and extend group also had a significant improvement from 0.73. So to conclude, by treat and extend and treat and observe, they are not only more convenient and cost effective methods which carries a fewer risk and fewer systemic side effects. There is nothing much to compare between treat and observe and treat and extend. The mean number of injections also remains stable, BCVA remains stable. So it's your choice to choose between treat and observe and treat and extend, right? Thank you.
Thank you. I think it's always a dilemma which one would be best, but I think overall a lot of studies have come about with treat and extend, because that tends to reduce the visits of the patient to the hospital. Possibly in the future we might all end, because you have more and more patients taking up monthly visits. Because for a treat and observe you'll need monthly visits. That's the biggest headache for. So that numbers are going to keep increasing.
And the patient loads are ever increasing. So you need to find a way out.